So tonight's echo is about the newly diagnosed patient with an endocrinologist's perspective for the didactic, and of course, a brilliant case coming up. Thanks. So I'd like to begin by acknowledging the traditional custodians of country throughout Western New South Wales and their connections to land, water and community. I pay respect to elders past, present and future, and extend that respect and a warm welcome to all First Nations people present today. Just regular housekeeping. Please turn on your webcams. It makes us feel more together and more part of a community, more with each other. But we do ask you to remain on mute except when you're speaking. We live and work in small communities, and sometimes possible that we do identify the patients involved in cases, and please, as we all do, work carefully to maintain patient confidentiality, even if you do recognise who the case may be about. Questions are welcomed, and I will be asking you throughout the session, but please do use the hand up feature, physically wave. You can even type something in chat if you don't feel like talking to the crowd, and I'll read it out dutifully for you. But we do encourage you to speak up. A reminder, as always, that our language matters. The words used to talk about diabetes affects the physical and emotional health of people living with diabetes. They also affect how people in society view people living with diabetes. Our words need to show that we care and remove bias and blame. So you might ask yourself, people with diabetes call themselves diabetic, so why shouldn't I? Well, evidence shows that 1 in 2 people find the label unacceptable and 1 in 4 find it harmful. People with diabetes are free to use whatever words they wish. Other people, especially those of us in healthcare, have a responsibility to engage all people affected by diabetes in positive and helpful ways. So has Manic managed to join us? He has. He's misnamed as Ali Sullivan on your screens. However, he's definitely Dr. Manic Mayadune, staff specialist physician and endocrinologist at Orange Health Service. He's also now the head of Department of General Medicine. So I'll hand over to Manic for the didactic session tonight.
So I have a tendency towards speaking a lot, and I'm going to cut myself short this time. So I'm going to try and tell you what's most relevant for you guys in the newly diagnosed patient. And I'm going to throw some numbers around for those of you who want to know specific numbers, but really I want you to take home the general concepts. And feel free to ask me questions at the end of the presentation. All right, so here's a nice little flow chart of how we look at diagnosing diabetes. And on the left-hand side, it also goes through pre-diabetes, which encapsulates impaired fasting glucose and impaired glucose tolerance. But in terms of the numbers we're looking at for diagnosis of diabetes outside of pregnancy, we're talking about fasting glucose of 7 or greater, 2-hour or random glucose of 11.1 or greater, and, we always get errors in test, which is why we like to repeat it at least once to confirm that that is a true reading before committing to a diagnosis. Then there's the HbA1c, which is more often than not how we diagnose our patients, because nowadays we can routinely do HbA1cs and 6.5% or greater. And we have got these other units, millimoles per mole, which are being gradually adopted internationally. But most of what we're having reported here is in percentage. So those are our thresholds for diagnosis. In terms of when people are diagnosed, so I'm going to have a specific lens for these patients because I work in general medicine in the inpatient setting as a large part of my practice. So I see a lot of those patients coming with diabetic ketoacidosis, hypoglycemic hyperosmolar state, hypoglycemia incidentally picked up because they've got another acute illness, and then pregnancy screening because we tend to be more proactive with that population. Now, things to consider when we make a diagnosis, it's easy enough to look at the number and go, oh, your HbA1c is above this, or your random blood glucose is above this, you've got diabetes. But really how we manage that patient is highly dependent on the diagnosis we're making. And that might be in pregnancy where you've got much tighter glycemic targets. or it might be, the difference between type 1 and type 2 diabetes and the risks associated with various medications. There is an overlap between the two, but you want to try and work out, are they more of an insulin resistance picture or are they more of an insulin deficiency picture? And what medications can I do to target their specific issues? So the things we're going to consider, in that we don't get that diagnosis straight away all the time, we need to buy ourselves a bit of time. So we're going to work on what is our pre-test probability for each specific type of diabetes. So what's their weight and what's their BMI? Because if they're overweight or obese and if they've got other features of metabolic syndrome, they're most likely going to have type 2 diabetes. And if you get that wrong and they actually have type 1 diabetes, they're still going to have an element of insulin resistance. And so you're far less likely to start them on insulin and hypo them, right? So you can still use type 2 diabetes medications in those metabolic syndrome patients with type 1 diabetes. Other factors that might push you towards type 2 diabetes might be polycystic ovary syndrome, Cushing's syndrome, acromegaly. There's a few others. Steroids tend to cause insulin resistance. And then you want to ask, does this patient have an autoimmune preponderance? So do they have Graves' disease? Do they have celiac disease? Do they have Addison's disease? Do they have rheumatoid? Because there's a large overlap between all of those conditions and other autoimmune conditions, namely, in this case, type 1 diabetes. What's their family history? Now, we know that type 2 diabetes has a much stronger genetic risk compared to type 1 diabetes, but type 2 diabetes is much more guided by lifestyle factors as well. So that can be difficult to tease apart the genetics versus, well, my parents are obese because of their lifestyle and I've taken on their lifestyle. However, if you've got someone with a strong family history of type 1 diabetes, they don't have metabolic syndrome, then they're far more likely to have type 1 diabetes as well. Do they have known pancreatic disease like chronic pancreatitis? So in the patients with alcohol excess, or if they've had a partial or complete pancreatectomy, you need to treat them like you do your type 1 diabetes patients because they will hypo if you treat them too aggressively. Have they had weight loss? Because if they've got weight loss, they're more likely to be in the type 1 diabetes camp because the glucose is not getting into their cells and they're peeing all of that out, and it's to do with insulin deficiency rather than insulin resistance. And then ketones relative to blood glucose. So lots of patients will come in with elevated ketones. That doesn't mean they've got type 1 diabetes, particularly if they've had nausea or vomiting. They might have a starvation ketosis as well. So really it's about, well, are the ketones disproportionately higher compared to their blood glucose level? So for example, if a patient came in with a ketone of 5 and their blood glucose was 12, then that's far more in keeping with type 1 diabetes versus having ketones of 5 and a blood glucose level of 40. That's probably going to be more of a HHS picture with type 2 diabetes and insulin resistance. Now, what are the investigations that you would do? So HbA1c to get an idea of what's happened over the past 3 months. Now, that's not cut and dry because you could have developed fulminant diabetes within a shorter period of time. Let's say you develop that over 2 weeks because you're on a checkpoint inhibitor for your melanoma, then the HbA1c could still be normal, but your random or measured blood glucose levels will be high. Fructosamine I've just mentioned briefly there because if you've got patients who have hematological issues, if they've got regular transfusions, or if they've got regular blood donations, let's say hemochromatosis, then those patients may not have an accurate HbA1c. Versus the fructosamine, which is based on an albumin assay and is a reflection of the past 2 to 3 weeks, might be a more accurate test for those patients. Now, the type 1 diabetes antibodies, there's 4 of them to choose from. 3 of those 4 is sufficient. And generally speaking, I test those first 3. So GAD, IA2, and zinc transporter 8. The reason being that insulin antibodies often are a bit difficult to interpret if they've had insulin exogenously. So if you've given them injections, have they developed antibodies to that injected insulin, or did they have those antibodies to start with? We don't know, and there's no way to clarify that. So I don't find it as helpful. But if they're insulin naive and you check their and the insulin antibodies are positive, then that's also in keeping with type 1 diabetes. The more antibodies you have, the more rapidly your diabetes is likely to progress into complete insulin deficiency. Now, C-peptide, I always check that with a paired venous glucose. It's not really useful without the glucose because you need to know that the glucose is high when the C-peptide is checked to make sure the C-peptide is appropriately elevated. So if that blood glucose level is 5 and the C-peptide is within the normal range, that doesn't tell you very much. If the glucose is 15 and the C-peptide is in the low normal range, then that's consistent with relative insulin deficiency, and you can lean more towards a type 1 picture. However, in the acutely unwell state, where their sugars have been high for a while, that can stun their beta cells in the pancreas, and that C-peptide might be falsely low. So oftentimes you need to check that again down the line when they're not acutely unwell. But if it's 0, then that's a useful result. And if it's 5 times normal, that's also a useful result because you can say, well, they've got type 2 diabetes. They're definitely not insulin deficient. Then you want to give them education on all of these things, which are fairly self-explanatory, so I won't go through them too much. So there's lots of information on NDSS and Diabetes Australia websites. In terms of the treatment, so you've got your primary type 2 medications. And I want to mention that metformin and the incretin analogs like semaglutide and tirzepatide are actually shown to be quite effective in type 1 diabetes as well. So you can use them in both groups. You don't want to use your SGLT2 inhibitors if you think they've got type 1 diabetes. I've given some general guidelines there around insulin dosing, and basically start conservatively and work your way up, rather than going too hard and hypoing them, because they will then have counter-regulatory spikes in their sugars after that, and it gets really messy really quickly. So targets. You want to target a glucose as low as tolerably possible without hypoglycemia if you're not using insulin or sulfonylurea. So your type 2 diabetes, the lower the better, right? As long as you don't hypo them. And then in terms of their risk, well, can I aim for 5 to 10? That would be perfect. But if they're having hypos, then relax to 6 to 12. If they're 80 years old and their prognosis is less than 10 years, then 8 to 14 is fine because it'll control their symptoms and they're not going to develop the long-term complications. I've put these cutoffs again for CGM targets. So time in range greater than 70% is a key there. And in pregnancy, that range is shifted to 3.5 to 7.8. Now, I'll quickly go through this case. I know there's not a whole lot of time, but she was an interesting one I saw recently. A 30-year-old who was sent to me from antenatal clinic, HbA1c of 9.2% with previous gestational diabetes in the last pregnancy, and a random glucose of 10.8. This was at, I think, 11 weeks gestation, not 121 weeks. She also had hyperemesis and so couldn't do the OGTT. So it's quite useful that we had a HbA1c that was interpretable. No diabetes in the family. And she was started on some Novorapid and Optisulin followed by Prodophane, but was hypoing overnight. And she had a BMI of about 20 pre-pregnancy. So she had this Freestyle Libre arm, which is quite useful. The problem was she was hypoing overnight. So she was actually getting a lot of time in range, but hypoing without long-acting insulin. So we did a couple of investigations. The C-peptide was mid-normal, but the glucose was only 6.6. Can't really interpret it. We checked the cortisol because a low cortisol would have explained the hypos. That was normal. And then finally, the antibodies came back and she was strongly positive for GAD antibodies. So she was diagnosed with type 1 diabetes and she's delivered at 37 weeks with a healthy baby after an insulin dextrose infusion for 24 hours beforehand. So I know I spoke very quickly and I've gone slightly over time, but Alex, maybe we might leave questions for later, shall we?
No, we've got 2 minutes.
Okay.
So any burning questions? Now's your chance.
You'll also have other chances because everyone knows where I work.
I look, I always take this opportunity to ask my own question if no one's quick enough. So, say like one common situation that I seem to find is someone comes in and they're suddenly found to have a finger prick blood sugar level 20 to 25 just on a random blood sugar level. And I feel like that's a very GP. They're walking around completely, well, they feel that they're asymptomatic, but you look into them a bit more and they're probably not. What's your approach there?
Yeah. I know that the guidelines say, hypoglycemia and symptoms. But really, I don't place too much emphasis on the symptoms because they're not going to determine your risk of developing complications. The symptoms really are more relevant around hypoglycemia and safety when driving or operating heavy machinery. When it comes to symptoms of hyperglycemia, for the vast majority of patients, that doesn't have a functional consequence unless they're polyuric and they're old and they've got other reasons they're going to fall and they've woken up at 3 a.m. and fallen off the bed and snapped their hip, then yeah, the symptoms are relevant. But otherwise, I don't really emphasize it too much. So if the numbers are consistent, and particularly if they're well into the teens and above, then I will make the diagnosis regardless.
Would you immediately start them on a basal insulin, those sort of levels?
Uh, I would if they also had elevated fasting glucose. So there is a proportion of patients like this lady actually, whose fasting and overnight glucose levels are really normal, if anything on the low side. They just have really poor, really impaired glucose tolerance, right? So they get a carbohydrate load and then they cannot manage that appropriately from a metabolic point of view. So the problem with giving them long-acting insulin there is you will hypo them overnight. So it really depends on the patterns, and it's really important to stress the importance of your diabetes patients documenting all of their blood glucose levels. And that doesn't have to be 4 times a day. I ask for twice a day. It's realistic. So fasting and then either pre-lunch, pre-dinner or bedtime, and they can rotate that second measurement. And the other thing I'll quickly mention here is the Dexcom One Plus. I'm not sure if anyone has been using those or their patients have been using those, but that's a new sensor targeted at type 2 diabetes. It's $65 for 10 days of continuous glucose monitoring. And I think that's going to change significantly what we can do with type 2 diabetes because of the data available.
Thanks. Anna, quickly. Yep.
Oh, sorry, it's probably not a quick one. I was just really interested in the insulin antibodies. I just came across a patient recently. I was looking back through his history, and about 10 years ago, he'd had those checked with the C-peptide and they were elevated, but he was on exogenous insulin at the time, and he just has a really unusual response to his insulin. And was only using basal at the time, but had these strange drops. And yeah, I just was curious whether you'd sort of repeat just the insulin antibodies or whether you do like a full screen with the other type 1 antibodies as well.
If he's already been on insulin, then I wouldn't check the insulin antibodies again, even that first insulin antibody that came back positive. If that was off insulin injections, then that's interpretable. But if they'd already had injections, it's hard to know what to do with it. So I would be checking the other antibodies as well to see whether this person has type 1 diabetes, because the alternative is a really rare syndrome, but it's called Hirata syndrome or insulin autoimmune syndrome. Basically where you get these antibodies to insulin that hold on to your insulin and then randomly release them at other times of the day, which can explain really erratic blood glucose profiles because the insulin secretion is then completely unpaired from what the glucose levels are doing. So that's a possible explanation for this person if they're totally random from one day to the next.
Yeah,
Uh,
thank you.
Ali, if it's okay with you, in the interest of time, we might just move on to the case presentation. Cool. So I neglected to mention our panelists tonight, as well as our case presenter at the beginning. So I'm Alex Hull. I'm a GP out at Molong, also joined by Alison Amor, a credentialed diabetes educator, Manik Mayadune, and Amanda Taylor, also a pharmacist and diabetes educator. Martin Watson, our usual fellow GP, fortunately for him, unfortunately for us, is overseas. And tonight we're joined by Anna Blackie, who is our case presenter. She's also a diabetes educator at Orange Aboriginal Medical Service, as well as the hub coordinator for Care Partnership Diabetes in Western New South Wales. I'll pass over to Anna now. I think we're going to hand over to Dr. Ivy Chua now to just tell us a bit more about Health Pathways, which has had a really exciting update in the type 2 diabetes. Ivy, over to you.
Thank you very much, Alex. For people who haven't been using Health Pathways before, basically the idea is that Health Pathways exists all over Australia, New Zealand, growing in the UK, Canada, and it's an amazing resource that is localised for each region. So in Western New South Wales, we've got a little team of us GPs supported by our program manager, Marianne Day, who spending time collating resources so that these can be used at the point of care. So the idea is it's not, a big comprehensive coverage in terms of guidelines for any of these topics by any means, but the ability to be able to click on it and go, oh, just need to grab that little bit of information that I can't quite remember in my consultation, to be able to click on it and open it up and just, support your assessment and management for patients. So type 2 diabetes exists on Western New South Wales Health Pathways. So for people who haven't used Health Pathways before, basically what you'll see is, there's usually red flags, and red flags take a slightly different meaning in Health Pathways compared to how we normally use the terminology red flags, but it's really just the things that are, if these things are present, problem, work quickly, and perhaps don't follow the rest of the pathway right then. Go and address these things first up. That's what it talks about. But you'll see a bit of background stuff, and any of these things in blue, click open, the drop boxes, the assessment side of things. Some of these things in blue will link you to other pages. So for example, this one here, confirmed diagnosis of type 2 diabetes. If you click on that, it actually takes you to the screening and diagnosis of diabetes page, and it's easy to get back to where you want to, back button there. And so we talked tonight about the newly diagnosed diabetic, and you can see here in the management section, quite a few of the things that we've talked about are incorporated into here when you open up the Dropbox. But won't click much more in that. I think it's hopefully fairly self-explanatory. Did want to highlight one other thing. All these request pages attached to Health Pathways are really the gold part of Health Pathways. Marianne spends an extraordinary amount of time trying to make these request pages as comprehensive as she can. So if we look at, for example, so you want to find a diabetes educator, the diabetes request page, click on the diabetes education. In the far west and western, you can go and look at your own region. So I'm based in Dubbo, so I'm Western New South Wales, Central, and you can have a look at what options I've got from the public diabetes educator perspective. And then further down, we've also got the private services listed. If people aren't listed on here, by all means, let Marianne know, because she will very happily add information to these request pages. But it does mean that, if wherever you are, you should be able to find the resources. Same goes for if you're looking for, say, an exercise physiologist. This search button is really helpful. Type in your exercise physiology request. There we go. And it will take you to that page. And similarly, you can look at what have we got in terms of public, which we don't really have in our area, but certainly the private options are there. So you can see there's plenty of the allied health therapies pertinent to diabetes care that you can fill up. And then last but not least, if you haven't already signed up with Health Pathways, there's a little QR code that you can link into and request a username and password to be able to have your access to Health Pathways. It's basically anyone who works in region and has, is a clinician, Marianne will be able to sort out a username and password for you.
Thanks very much, Ivy. Great. And our next Echo session will be on the 12th of June, Thursday the 12th of June. And then shortly thereafter on the 14th of June in Dubbo is the Western New South Wales Diabetes Education Day. So very much hoping you can all join us there in Dubbo on that day. So I think that's it for tonight. Thank you very much for attending and for all your fantastic contributions. And we look forward to seeing you at the next session. Good night.
Good night. Thank you, everyone.